Welcome. This is Physio Insight. Welcome everybody to our second podcast in the series ACL Injury. We are incredibly happy with the interview which is now following with Professor Dr. Freddie Fu. Fu was president of the Pennsylvania Orthopedic Society and in 2008 assumed the presidency of the American Orthopedic Society for Sports Medicine and was the first foreign-born president in the AOSSM 40 years history. In 2009 he was named president of International Society of Arthroscopy, Knee Surgery and Orthopedic Sports Medicine. He and his team completed more than 100 studies and treated hundreds of athletes. Most known athlete is, for instance, Zlatan Ibrahimovic. In this interview, he will take us into the history of ACL surgery in the last 50 years, and he will explain the so-called 6 principle of ACL surgery. Furthermore, he will give inside information about Zlatan's surgery, and he will tell us something about the essence of the collaboration between physical therapy, orthopedics, and patients. I would say enjoy the interview. Good morning.
Good morning. You're in the Netherlands?
I'm in the Netherlands, near Amsterdam, about 45 kilometers from Amsterdam. Well, shall I start with the first question, Dr. Fu? That's about what changed during your career in surgery.
I think there's some positive change, but there are some also change that doesn't advance our whole ACL trend. So the changes is that now I think therapists and doctors are really attacking the ACL itself. Mm-hmm. So in the 70s, when I started, we did not even address the ACL itself. We extract other part of the knee, the extracticular, medial side, lateral side, and then only in the early 80s we start to actually put a graft in and do things to address the ACL as an issue. And of course, in the mid 80s, we start arthroscopic surgery. That in a way is good, but in a way it's bad. It's good because it's less invasive. Like you say, I used to make a very big incision in the early 80s to do the ACL surgery, but so in the mid 80s, the incision is tiny. But then the problem with that is surgeons become a little bit getting complacent, and they think they can do it fast, efficient, and up that they're not doing that well.
Right.
So there are a lot of, it's like any, I would say, technology. I would say that disruptive technology. So it's good, it's disruptive, it's good. But then there's some price to pay. So, for example, I did a lot of surgery in fan technique that are definitely completely not anatomical technique. That is probably put patient at risk for osteoarthritis. Now, maybe they can go back to play, the brick is working, but not that well. Okay, so I think that only in the last 20 years we start to advance into 3 things that I can see that takes time to develop. One is the anatomy, still basic, need to know more about it. And number 2 is individualize of the ACL, which still people have to learn about because there's big variation.
That's
And
about
ACL
the individualized anatomic approach you're doing.
Yes, I
Yes.
think that people don't realize. So people first start with anatomical approach, which is a very good thing. But people assume anatomical means that it's the same thing in every case, because people still want to do it fast, efficient, and easy. Okay, this is what industry wants and surgeon wants. But the truth is, there's no two ACL the same. And in fact, the ACL all come from the fact there's the bony morphology to take the ACL, not the ACL itself.
No.
So to understand the ACL itself, you have to understand the bony morphology, which is a three-dimensional, complicated, which is still a way to go. So the individualized thing has become a little more complex. And I think if we start to pay attention to individualize, I think we can correct 10 to 15% of the issue we see in our surgery. And the last thing, I think the changes is value-based. What I mean is that in the last 30, 40 years, I have seen many things that come and go. For example, in the 80s, we started to introduce artificial ligament.
That's right, yeah.
Which turned out to be, in some cases, very bad, because we did study to show that when the wear particles start to form in Gore-Tex graft, it can destroy the cartilage. So of course, the marketing is that, well, you can go back fast and early, but then maybe 1 year later, your knee is going to be all messed up. So there are many things like that. Now, the extrarticular, I started in the 70s. I was doing extrarticular with my boss, Ferguson, and other people. In fact, when I started my practice, for the first 2 years, that's all I did. And then after those surgery doesn't last that long, because those are not anatomical. And in fact, what they do is, in my opinion, they change the AP translation. In other words, the extrarticular pull back the tibia.
Yes.
Immediately. In fact, I was on the table and say, oh, look at that. I do this extrarticular. Look at it, doesn't shift and everything. So the thing is, it doesn't shift because it controls rotation, thing like people will say about today. Because it pull back the tibia, so you cannot shift and have those phenomena as you see with a torn ACL. But unfortunately, those surgery, the extrarticular stretch out, and they're going to return sometime now. Interestingly, I revised many of my own extrarticular. And what you see is interesting. Those extrarticular never torn like the ACL, okay?
Okay.
You look at what it is, it's always just a stretch, but it's always there.
But then probably the biomechanics changed through that.
Well, it just stretch out. So essentially, recently, we actually, in our lab, we have a very sophisticated lab in vivo kinematics.
Yes.
And in fact, the first time in the world, we showed that if you do extrarticular versus no extrarticular, when you walk the patient in the first 6 months after surgery versus 1 year, at 6 months, the extrarticular actually, when you daily function walking, the biggest thing they do is to pull back the tibia.
Yes.
Nothing about rotation. In fact, in some cases, it's up to 4 millimeters. Now, these are walking. These are, biplane X-ray, and it's just really seeing. But interestingly, by 1 year, those effects are gone. Okay, so if you put the ACL graft in, maybe the extrarticular can protect the graft when it heals. Now, the other advance is, I would say that I would give you 6 principles that are very important because I belong to a group called the ACL study group.
I know, yes.
It's a famous group, and many people from all over the world come almost, in the 80s. I've been in since the 80s. So now the interesting thing is we talk about the same topic. It's like recycle.
That's right.
Where you put this tunnel, where to rehab, fast rehab, slower rehab. You use patellar tendon, use hamstring cord tendon. Recycle topic, and it's just go back to the same thing. No. In fact, I was in a meeting recently, and the question people asked at the end same question you asked 30 years ago. How do you tension the ACL? What flexion angle you fix the ACL? Things like that. I mean, these are like topics that are silly because is not in vivo, people think will change. So the sixth principle, I think that I have thought of very carefully. Takes me a long time to do that. And I think I work with other people to make sure. So the first principle is the ACL is dynamic.
That's right.
Okay? It's not like static.
No.
So what we see in the dissection may be beautiful, but it is not. There's no isometry. Nothing like that. Because
does that has to do with the anterior medial part and the posterior part of the...
Yeah, there are two bundles, but actually
yes.
I'm going to tell you what it is.
Yes.
So I'm going to go ahead and tell you how it is. So first is dynamic. So in fact, the isometric concept put forward in the 80s are pretty wrong. Because actually, it's like the cartilage. We know the cartilage when you walk and run. It's squeezed together and then relax, okay? Right. So it's like a sponge, okay?
Right.
Like a sponge. The ACL is the same. Actually, when you run and walk, the ACL squeeze together and stretch.
Right.
Up to 30%.
How many percent do you say?
30%. Yeah, 20 to 30%.
Really?
And I'm going to tell you why. So we are always worried about biomechanics. Biomechanics will tell you, you have to worry about ACL graft because if you stretch the ACL at 8%, it will fail, okay? Which is fine, okay? We know that you fail. But we don't know that actually. They squeeze together like a cartilage when you run because we were able to measure the intra-distance between insertion sites when people were running in the left. And each patient that we work on take 40 hours of computer work to have those conclusions. And I have done it for like 15, 20 years. It's not like just one study. I'm talking about hundreds, thousands of subjects. It's definitely true. So one is dynamic, and which is weird to say. So, for example, right now people say that, extraarticular is incredible because it stops the rotation, but it's not in vivo. It's just like I show you in vivo, extraarticular, just to AP translation. Because every day you walk, you don't rotate your knee.
No, that's right.
You don't rotate your knee, you just like walk. Okay, so that's one thing. And number two is those bundles in the 90s when we discussed for the bundle and we did study. I worked with Zlatan Ibrahimovic, very well famous, guy, and we try to say that, you must do reconstruct two bundles. You must do think that AM and PL to do this. So it sounded a very good story, and which is a strict biomechanic. But I hate to say that biomechanic is good, but is it not in vivo, it's not biological.
No, that's right.
Actually, as I go along, I find a few things. It's not the bundle you need construction. It's the amount of percentage of insertion site you need to replace. Now, the bundle over there is interesting. So when I start the research in this field, anatomical field, I actually went to the fetus. 20-month-old stillborn babies that just came out, and we were able to dissect the next day with a microscope. And we find that two bundles, oh my God, okay. So I conclude right away, oh my God, you are born with two bundles. But what we find even more interesting is there's blood vessels between AM and PO bundle. And I work with a very famous scientist, Johnny Hewitt. And we actually biopsy those areas and find stem cells between the bundle. And actually, then we went to the surgery in the torn ACL, and also we did the same thing. So essentially, we find that the blood vessels come from the anterior horn of the lateral meniscus many times. They also come from the top, and they supply the ACL daily function. So the ACL survive not by diffusion. They survive, and the way it works is this. When the ACL squeeze together, I haven't proved it scientifically yet, the blood supply will go in.
Right.
But when you stretch, then it squeeze out, okay?
Right.
So this is why you need two bundle to allow that. In other words, if you do a one bundle surgery, and if you allow the proper healing and the proper, rehabilitation, maybe after even 2 years.
Yes.
those bundle will all reform because this is how nature need to support the ACL. So, in other words, it's biological. It's biological. The ACL is biological. It's not like a static.
All right.
So the third principle is the bony morphology is absolutely critical. Now, how do I find out? I have a chance to meet one of the more foremost paleontologists in the world. His name is Owen Lovejoy. I don't know if you know him, but he discovered Lucy in Africa together with the French and other people there, a whole team, American and French. I forget what team. The 3 teams for 3 countries. And actually, so Lucy, I talked to him about. So I say, well, how do you look at these bones? Okay.
Right.
Well, he said it's very simple. I look at all these old bones, and I can determine the motion by looking at the, morphology of the condyle. And in fact, I can even put in what ligament they need. Okay. All right. So essentially, this is a big, and in fact, I have Lucy replica in the home. There's 2 bundles too. Okay, you can, because it's upright walking. So from then on, I went to the animal world. So in the zoo and in Africa, and I went to Africa, we look at 38 species of animal. And in the zoo, we examine the animal rotation when they are under general. Every 5 years or 10 years, they go to sleep. You be checked the whole body, okay? And when they die in the zoo, we open up the knee and look at the ACL and the morphology of the bone. Do 2 CAT scan too. So it's 5 years of what we're 38 species of animals. And many of those animals have more rotation than human being. And they have 3 bundles, many of them, okay?
3 bundles?
Many of them have 3 bundles. Because they need a blood supply, because they need more substance.
More rotation, yes.
There's nothing to do with how many bundles you need for biomechanics.
No.
You need those blood supply to survive it. That's all.
Right.
And also the bony morphology will dictate how much ACL you need. Okay, if the ACL is more, then you need more rotation. You may have more rotation to support it. And also the meniscus size is different. So for example, just to tell you, for example, lemur is the most primitive primate, and the lemur is the only species that they have 2 extrarticular lateral ligament on the outside. After the lemur, there's none. So this is why the new ligament is called the ALL. I'm not sure it's really real, but people make it real now.
All right.
Because it's heavily, promoted by industry and consultants. Okay. So this is the other concept. Okay, the bony morphology to me dictate the bundles, and which we need to understand. And the 4th thing is the variation. Okay, variation is important. Now, do you know that in a human being, the smallest size ACL in the insertion site on the tibia and the biggest one are 3 times differences. 3 times, okay? I have measured thousands of them doing surgery. Now, cadaverous, interestingly, is not very accurate. I'm going to tell you why, okay? So you need to do in vivo measurement on live patient to do that. And you got to take the time. So the unfortunately thing I told you, most surgeons do not want to take the time. They want to go in, and typically they will shave off everything, they drill the tunnel through, and they're done because they want to finish the case and do the next one. Now, I used to do that in the 90s. I used to do 10, even 15 ACL one day. And each ACL is not more than 30 minutes because I use allograft at the time too, which is a bad thing, okay? And I apply allograft, which I know is not a very good thing now. But essentially, what we find is, the variation is so important. For example, the femoral insertion site in most time is smaller than the tibial side, but in 10% is equal or bigger. Why is that? Because the morphology dictates how to make. So the variation is important. There's no 2 ACL the same. How about that? It's like your fingerprint, okay? Now, the last thing is aging. The ACL age too. So Southfield Wu in 1991 already showed that a 20 years old ACL and 80 years old ACL have 5 times mechanical differences. 5 times, okay? But unfortunately, most of our study in dissection are done in old cadaver 80 years old. So those have a lot of degenerative changes. And so this is why our conclusion, although are well-intentioned, okay?
Yes.
People who are nice, but they are wrong, okay? For example, people say the ACL is a ribbon, the ACL is a C-shaped insertion site. It's not. If you look at a young 16 years old, the ACL is big oval insertion site. There are two bundles. It's beautiful, okay? I can show you thousands of cases. I document everyone. So if you look at those 6 principles, dynamic, biological,
blood vessels,
morphology, variation, and aging. If you understand those 6 principles, I believe then you can improve on the outcome of ACL.
Right.
Otherwise, all this, I do this tunnel, I do the extraticular, I do this, graph. It's nonsense. It's okay, you're going to get some success. You're going to get success. You're going to get maybe 80% success, but then you're going to miss something. You're going to miss about 10, 15%. So the question is, do you want to be 100% ACL surgeon? Do you want to call yourself an expert and do the best for the patient? So unless you understand those principles, I don't think you should be called expert. Right. You can call you're just a general guy doing some ACL and doing fast, and maybe get the patient back to some sports, and maybe not quite right. Okay, maybe something is off. Okay, something like that. Okay, so these are the principles. I would say that, and this is what I'm preaching to everybody. If you really want to improve on the ACL, these are the things you have to do research. Now, I cannot do it on my own. I have a big lab, and many people. I need the whole world to do all the things I'm telling you about.
Right.
I want you to do it, okay? Everybody, okay? This is how we can improve. Not just, let's drill holes in the AM position. Let's drill this in the middle position. It's silly, okay? It's really silly to think about it. Okay?
When you talk about the blood vessels and the biological point number 2 you just mentioned, is that why you are looking at the quadriceps tendon to use as a graft?
I know it's a quadriceps tendon now. I'm going to tell you how we do surgery.
Right.
So first, when the patient gets hurt and they have an MRI done, first we analyze the MRI, okay? We measure both 2-dimensional and 3-dimensional on the tibial insertion site and see the size of the insertion site. So like I told you, if you look at the sagittal, MI on the sagittal plane, the smallest is 8, the biggest is 26.
Okay? My God, that's a big difference.
Yeah, big difference.
Yes.
So next time you can look at the quad tendon on the MRI. You can see the size. You can look at the patella itself, how thick it is.
Right.
And you look at the patella tendon. Now, recently, in the last 5-6 years, I'm using ultrasound to look at the hamstrings. Okay? So before the operation, I will have an idea the size of all those grafts that will match your insertion site. Okay? And the nice thing about the quadriceps is not because I like it more and try to promote it, because it's a versatile. You can use just a soft tissue part, or you can use a bone block. Because when you do the MI measurement, you can also see the length of the ACL. The length of the ACL is interesting. The shortest one is about 25. The longest one is about 45. It's reported already. Okay, so again, there's 20 millimeter differences. You cannot do the same, size. So if the hamstring is short, it may not have enough length to do that. Okay, so the quad will tell you length because the MI and the ultrasound will tell how long the quadriceps is. Okay, and the patella tendon. Now, interestingly, the patella tendon is also a very good graph, but typically the patella tendon is about half the thickness of the quad tendon. All right, now, and you can say, well, the patella tendon people do well. Yes, they do well because when you put the patella tendon graph in, it will hypertrophy. And in fact, it's just a paper published by Shino from Japan. They documented the patella tendon hypertrophy 100% in the first year. And then it took almost 4 years to get big, small. Right. So you need to get it mature. Now, the good thing about the quad tendon is you don't have to hypertrophy as much.
No, that's right. That's right. Yes.
It's already there. So it gives you instant. This is why when people say, well, I want to do extrarticular, I want to do thing. Our thinking is the extrarticular will help the healing of the graft, protect the healing of the graft. This is the biggest thing, not because you're going to control rotation. So for the first 6 months, when the graft is healing, the extrarticular operation will prevent this AP translation when you walk. Yeah, and allow the graft to heal better, things like that. And then hopefully by 1 year, it'll be big enough to be strong. But if you not protect it, let it move a lot, then the graft will be, not very good. Okay, so we all use very common sense, but we use science to prove it also. And the hamstring is very good graft too. I still like to use it a lot, but sometimes it's really small. But if you see the small hamstring, you can see the size from the ultrasound. We publish already on that too. So you prefer to do the quad tendon. And this is why not, because we like it more. Because the quad tendon, the size. Right. You the patella tendon. Also, the patella thickness is important too. If the thickness of the patella is less than 14 thickness, you shouldn't take the bone block. That's too dangerous to fracture. I know it because I fractured 3 or 4. Oh my God. And then I learned from that, do study and show this big variation. So now any patella thickness less than 14 millimeters, I don't recommend taking the bone block at all, even for a patella tendon. It's a little dangerous to do that. So those are all very simple anatomical measurements. Right. Just because I like the quad tendon, because the quad tendon is like more versatile for the purposes. But I would recommend the surgeon should know every graft, should use every graft, and don't be just stuck with one graft, because this is not how life is, okay? You should understand everything.
But it will take a lot of time to do all the measurements. How do you do that in your...
No, the MRI, my fellow Kevin and other people do it. It just takes 5 minutes.
Yeah, that's right. That's right.
Yeah. In fact, less than 5 minutes.
Right.
And now the ultrasound, it takes time. Okay. Now the ultrasound, of course, I have a very expensive one. I'm not talking about a simple ultrasound. I have an ultrasound machine that costs $350,000. Okay. And I have an ultrasound specialist, Dr. Onishi, from the clinic trained and worked with us. And he came every Monday morning just for about 4 hours with me. And we do all the acute ACL patients. They come in. Not many, like Phil. I don't practice anymore because I've done too many ACL. So if you do a lot of ACL, you cannot do what I'm doing as much. Okay? Because
no, that's right.
So now he can take time, because he do a lot of measurement of the injury. He looked at these, for example, extrarticular injury. So we don't see the injury that people talk about in extrarticular too. Okay, we use ultrasound, MRI, and also we look at intrarticular in surgery. So with all the information from the MRI, ultrasound, then we conclude what graft to use to tell the patient.
That's right.
But I also tell the patient that I may change my mind during surgery. Because during surgery, I would use a ruler, simple ruler, to remeasure the insertion site size and determine, okay? And sometimes the measurement, MI, especially from out of town, the MI not very good. So they may be wrong, okay? The one time in the office is very good, so I would trust it, okay? But then I have published 2 papers on it already, HSN papers, to show 2-dimensional, 3-dimensional, correlation with intra-op measurement versus the MR. Okay, so everything I talk to you about is quite scientifically done.
Right.
So again, it takes a little bit of time. So I would say during surgery, it takes about 10 minutes more because of this measurement, or even less. Okay, so all the time is not a lot, but it's just look. If you're gonna fix your house, you want your carpenter to do your. You don't want your room to be crooked.
No, that's right.
Same way, okay? We want to put the right size of graft where it is. So we look at the insertion site, the femoral site, tibial site. In fact, when we do surgery, the biggest thing we to do is to look at the pathology. Look at how the ACL was torn, the bundle was there, where is it attached. Those are all the things we're looking at. And with that information, we can then measure the size and go from there. So And so those are the conclusion we need to make. So this is what makes an anatomical individualized approach. That's about it. And the thing I want to tell you, it doesn't cost any money.
No.
There's no industry like me because I don't really sell any product.
No, that's right. That's right.
Zero. Okay. So people, the industry do not like to invite me because I don't going to happen to sell some screws or something like that. Okay. And if I told people that do the most simple fixation, the simple thing that I do 30 years ago, do the cheapest technique. Okay. This is why it's value-based.
Yes.
Don't waste money. Your country is good, socialized medicine, but America is the number one healthcare money used in the world.
Yes.
20%, and we are ranked like 35 in the whole world in the healthcare. So why is that? Because all this money are being wasted.
Yes.
On treatment that are not useful and not helpful and maybe harmful. Okay. Okay. In orthopedic, we think it's about 30 to 40%.
Yes.
In cancer, maybe even 80%. Okay. But in a country like you cannot. The government will not let you do that. Okay. Say, well, let's not do this operation, or let's not do this. Okay. So it's more easier than for the surgeon in your country. Okay?
So if I understand you correctly, you use different grafts. You measure and then you decide which graft you do. That means that the physical therapy afterwards is for every patient different, because the quadriceps tendon needs another approach than, for instance, the patella tendon.
Well, a little bit different, but not so horrible different. Okay?
No?
A little bit.
Is it perhaps also important what kind of sports people do, or what kind of yes?
Exactly. So again, the graft choice is not the size, but the type of sports and the professional and all those things you take into consideration.
Yes.
Means okay. You're right. So the anatomy is one factor. Okay.
Yes.
For the sports, female, male, and all those things. And just give you a very interesting, people talk about hyperextension. Okay, you gotta regain it. The most simple way to get your hyperextension back is to do the anatomical individualized instruction, not to do a graft, different graft, or do an extraticular, nothing. No. I can tell you from my experience, I have a young lady. She is about -15 hyperextension. 28. This is about 6 years ago now. And when I go in her knee and measure it, she is the smallest ACL insertion site I have ever seen in my life. Okay. So so we use a hamstring graft and only 6 millimeters. Six. Because we cut it down because the insertion site is so small. So now with MI and 1 year, look beautiful, and now she is 5-6 years. I just saw her. She's still maintaining -15 hyperextension. And I think that if I put in an 8 or 9 graft, I would never get to hyperextension. No. I mean, I think what the therapists do. Right. So the best way is to understand nature.
That's
in nature, you get hyperextension by the graft you do. And people have nonsense. So while you have a small graft, you retear. Nature will determine, okay, if it's going to retear, okay? And nothing to do with say, well, it's small, it's going to tear, okay? The shit's fine, okay? So essentially, follow nature. Follow anatomy, individualize. Right. So, there was a case that I almost should I do 6 millimeter graft, and I did it, and exactly what it means. She is the most hyperextension patient I've ever seen. -15. I have a picture to show you.
Incredible.
You love it.
Incredible.
And then I told you she has a 6 millimeters hamstring graft, and I have MI to show the healing. And things like that. It's incredible to me. So we took nonsense about extraticular, about graft hamstring. It doesn't matter. You just put it in the right size, and it'll be fine.
Okay. Dr. Fu, could you tell me what the importance is of the collaboration between the surgeon and the PT?
Of course, very important. And I always tell the story about Zlatan. I operate Zlatan with Volker, the cell, and I told him that, hey, Zlatan picked me, and as a surgeon, with Dr. Musel, which is fantastic. I'm really honored to do that. And that, by the way, when he turned his ACL, it's a really true story. There are 50 surgeons from all over the world offer surgery to him.
No.
All right. Now, I don't know him personally.
Yes.
I don't know his agent, but he's from Sweden. And they're a scientific country. So he asked his Sweden doctor, who are the best scientific surgeon in the world doing ACL. So I have the number one publication in the world and everything. And, I made a Swedish fan. So they come to me. And the fact is, the newspaper already say he's coming to me before I know about it. It's a work down from Milan.
I saw that in an interview, yes.
Yeah, because probably the agent called the Milan club to find my telephone number because they don't know my number.
No.
So the word is out for my fellow in Brazil. Hey, I heard Zlatan is coming to you. I say, I was in Florida on the meeting. I said, come on, I don't know anything about it. So finally the agent called me and I say, sure. I mean, but essentially, I never market myself. I don't market myself, you understand? We don't do this marketing thing to attract patient. So he came and we did a quad tendon with bone block and also repair the outside. And by the way, I never see so-called ALL ligament on him. He has outside injury, and we repair everything. It's just anatomical what nature give you. Now the thing about Zlatan different is he's genetically gifted.
He is, yes.
Yeah, he's not much changes are treated at the age of 37 at a time.
Incredible.
He come back fast, which is I don't like, but he did. We have MI every month. Every month the healing, and it looked really fantastic. So he came back first day in 7 months, which I don't like. It's too early, okay, for me. But he scored a goal, in fact. And then, but he didn't really play well until 1 year or longer now. So when I give a lecture, this is the last slide I usually use. I say, look, he scored this incredible goal. I would give myself and Volker 10% of the credit for success. I would give the therapist 40% of the credit. And I would give Zlatan 50%.
That's right. That's right.
What I tell the surgeon. And I say, surgeon, you guys, don't think you are so great, okay? Don't think you're the best. If you're lucky to operate on a guy like Zlatan, nobody can make Zlatan look great, okay? So I take a lot of pride in taking care of him the best I can. What I'm saying, it is not me. I'm sure Zlatan will do well too in some way, maybe not exactly like that, okay? So I would put a therapist. And so in my office, my therapist is right there. I talk to them all the time. And I also find therapists over the country. For example, I did operate on a gentleman from Houston, Texas. And I'm able to find my therapist I trained back in Houston so they can follow with him. And they know all my protocol to do that, okay? So therapist is so important. And for example, specialty with motion problem and things like that. We want to correct it right away. We're not going to wait, okay? We communicate all the time. We talk all the time on the phone.
Well, that's right. Do you think there's a difference between amateur athletes and professional athletes in how would I say? We're always talking about level 1 sporters or level 2 or level 3. What's your opinion on surgery on amateur sports people?
I mean, the approach is no different.
No.
The approach is the same, okay? Maybe craft choice is a little different. But of course, professional athletes are eliminated by selection. They are really top tier people. They have better muscle. They may have better. For example, I'm going to tell you an incredible story. I operate on a lady 70 years old recently. So it turned out she turned an ACL 55 years ago on the other side. Yeah, she's a professional ballerina.
Right.
She had her surgery done, and she did okay. But she turned the other side, and she became unstable both ACL. So I fixed the new side, and then they said, why don't you do the other side? So when I do the other side, this lady have almost no arthritic changes, despite the fact she's a 50 years old torn ACL.
Incredible, yeah.
And I asked him, is there anything different about you. Say, well, I did one of those genetic testing, about my genetic. And one of the things they say, I have very good sports gene. I say, what do you mean by that? Probably she has a very strong, fast twitch muscle fibers. I have no idea.
No.
So that may protect the cell in some way, Maybe those athletes may have all those incredible genetics, protection. It's like Zlatan. I mean, my God, this guy is now 39 years old. Right. He is still playing in the top of the game, and he has not much wear and tear. And I mean, so people now. But on hand, I have seen like 20 years old professional. The friend on the ACL, they already have damage to the cartilage, and I'm not sure how far they can go. It depends on what we do the best for them. Okay, it's not ACL. It's the post-traumatic arthritic changes that can occur a few years later, right? You know that. Okay?
Right. And there's another question I have for you. I read the article, treatment after ACL injury. That was, I guess, from the Panther Symposium. And it stated that early surgery by level 1 sport would be preferable than later surgery. What is your opinion?
Well, I think the only problem is if the level 1 people want to go back without the surgery, they can torn the meniscus and other things.
That's right.
Big problem. And even in the Swedish study, the randomized trial to show surgery, no surgery, no differences at 2 years in New England Journal of Medicine. Very fantastic. But if you look at the fine print, the ones that are treated without surgery have more meniscus tear and more instability. Okay. So, but people live with it, and in Sweden, it's socialized medicine, so it's okay. This is how I live. It's fine. Okay.
Yes.
So the quality of life is the same, but then there's really some, I would say, objective differences. Okay?
Right.
Well, if you turn the meniscus and all of a sudden it become a long-term problem, that's a problem. Right? So the ACL is a protective of the cartilage and meniscus, and the thing is, we know that when you turn the ACL. You're going to already have a potential to develop traumatic arthritis. In fact, I worked a lot of doing 30 years ago. So first thing is the trauma from the tear.
Right.
Now, you can bone bruise and meniscus tear. And secondly, do you know that? You know Hans Passner, his name? Hans Passner? You don't know him.
No.
Very famous, he passed away. And 30 years ago in the early 90s, I and him did study 100 patients to show that when you turn the ACL, you have a high cytokines level in your knee up to 6 months. So those are destructive enzymes that can potentially destroy. And thirdly, genetics, I told you. That's people like Zlatan, genetically so good, okay? And the size of the ACL. And lastly, the kinematic. So in other words, if you have a three-dimensional tibias look different, you may predispose to more stretching, and also if you have the ACL done wrong, about not in what position, you're going to get that too. So what I'm saying is a multi-factors to get this arthritic changes. Okay?
Are you in favor to do surgery fast after the injury or later after the injury?
Well, we talk to the patients. We give them the choice. Okay. Now I have a unique situation for me. Okay. I turned my ACL 2 weeks before 9/11.
Oh my God!
I was hit by a car in my bike. Okay, and I tore my MCL, ACL, open fracture of the tibia.
Oh my God!
So in fact, I didn't even know the ACL was torn until a little bit later, because when they do the debridement and fixing the fracture. So I decided not to have ACL done because I rehab my fractures and open fractures. Okay, it took me about 1 year. So I have no ACL surgery in my ACL. So I always tell the patient, by the way, you can always do without surgery.
Yes, all right. Now, what I mean is how many time between the incident and the surgery is preferable for you.
Yeah, I understand, but let me get back to the time, okay?
Yes.
So now, also in the early 90s, I and Dr. Hanna and also Shelbourne differently to two different locations.
Right.
We find out that if you're going to do early surgery, you can have a high incidence of stiff knee.
Right.
In some cases. So in other words, we found out that it's not the time, it's how angry the knee is, okay?
Right, right.
If your knee is angry, it's swollen, painful, no motion.
Mm-hmm.
Remember I told you the study biologically there are high level of cytokines
Right.
in there? I mean, you don't want to do so. Just like you married?
Yes, yes.
Okay, so if your wife is upset,
Mm-hmm.
you're not gonna upset her more,
Yes.
right? You're gonna take her to,
Take a walk. Take a walk.
Exactly. Same for the knee.
Yes.
You gotta tell the knee, hey, can you calm down?
Mm-hmm.
So if the knee is calmed down very fast, 10 days you can do it, but sometimes, if there's no swelling, no pain, you can probably do it right away too, okay?
Right, right.
If you're really angry,
Mm-hmm.
I don't think it's a good idea because we have up to 25% of stiff knee,
Mm-hmm.
and so is shoulder in front. So we prefer to wait, but not a time limit because people give 6 weeks. It's silly, okay, or longer. So of course you gotta talk to the patient whether you want a surgery. Like I said, because I had no surgery, you don't have the surgery. But if you want to play sports, you want to prevent meniscus tear, and in America there's a timetable because they want to the next season, right? If you wait, you may miss 2 seasons, okay?
Right.
And if you want to go professional, you will miss everything, okay? So there's a time limit that you want to do it right away, okay?
Right.
So for me, a doctor, I don't care. So this the whole thing. You just wait until the knee is not upset. It's not so pissed off. I told
Right.
patients.
Right.
Don't have the knee being a pissed off knee. Calm it down and then operate. Okay, makes sense, right?
Right. And what do you consider is the minimal rehab time before return to sports? Because that's a discussion lately as well.
Right.
So what do you see? You just
Well, let me tell you, it's very simple. So in the 90s, when I do many arthroscopic transtibial non-anatomical approach, I'll tell the patient that you'll be back in 6 months and your success is 90%. It's a lie, obviously.
Yes.
Okay? So now I think it's complicated because again, there are a few factors. Of course, for the therapy part, you want to get your motion. You can get strength, swelling. So that's important, right? You do functional testing, all those things are important.
Right.
So this, okay? So the new thing I add on is the healing of the graft, okay? So the graft takes time to heal.
Right.
And now how do I learn that? Because in about 15, 20 years ago, I have a very famous player. And he is, at 6'1", he's fantastic looking. The muscle is good. And actually, I did an MRI on him too. And the MRI looks fantastic, except it's a very high signal. At the time, I don't realize the high signal means it's not mature, So we went back to play and retarded, in 6 months. Okay, so, oh my God, I better learn a little bit more. So I think that now you look at the muscle, you have to look at motion, you look at swelling, and of course, work with a therapist. Are they ready from a therapist
Point
viewpoint?
of view.
And I have Jerry again, who's very famous and good too. So, and then from my point of view, I will see the maturity of the graft, okay? And this is why the quad tendon is good because it's already big enough right away.
Right.
You don't need the hypertrophy as much as the other, graft, okay? So this is one advantage of a quad tendon. It's already double the size of a patellar tendon, for example. Initially, you start out very good. So those are all the factors. So right now, I would say, I usually in the office, I will tell the patient 9 months to 1 year, but I actually go back to 3 months. I have a professional cricket player from India, number 1 player in the world, okay?
Yes.
The best player. I offered on him, he went back to India. He's playing in 3 months without asking me. I find out because my friend from South Africa and Australia said, hey, the offer on him, he's playing already in 3 months. I didn't know that. So actually, he was fine. He's genetically like Zlatan now. Interestingly, this guy comes back 3 years later for the other knee. And I beg him, please don't come back in 3 months. So you wait 5 months. So people genetically can do that, okay? But this is not what we recommend, okay? Because most of the patients I have are high school amateur athlete. They don't have the means and the genetic composition to be like, gifted like that, okay? Like starting at 7 months is very fast too, okay? So when I understand people want to get paid to play in those countries, okay?
Right.
But I think for a regular high school amateur, you shouldn't really be in a hurry. You should let it heal, go back. So I would really monitor the patient carefully, with all those factors with the therapist and healing. And also the newest thing is I'm using ultrasound to look at healing. Our ultrasound can look at vascularity. It's only
with the Doppler. Yeah.
So it typically, if you put a graph in, the vascularity is high. So by about 9 months, 1 year, it becomes equal to the other side.
Okay.
So it shows the maturity of the graph. So at least there's a quick way. So at 6 months, if I see high vascularity, I'll tell a patient, hey, it's still healing rigorously, okay? You should wait a little bit, okay? So that at least that is not expensive, because MI can be expensive in my country.
Right. Well, here as well.
I will do that because they will do it. Like Zlatan have an MI every month.
Yeah.
Every month, okay? So
but Zlatan is making a lot of money, Dr. Fu.
and Manchester United have their own MI. They have their own MI in their stadium.
Right. Incredible.
We have no problem.
It's incredible. Do you have what are false stories you hear in your practice from patients? What are stubborn nonsense stories which patients believe about ACL injuries?
Yeah, I won't say it's really stupid. Right now, there's a big push for repair of the ACL, and I don't think it's totally crazy because, like I say, but it's like anything in life, the is about indications. Okay, so for example, the extrarticular in my practice, about 5% cases, so there's indication. We like to use it in smaller graft and all those things, okay? But for example, people now pushing for repair, and I believe there's some indication for that, but not in the cases like the industry like to push it, and they actually, not just repair, they put it in artificial ligament and all those things to do it, okay? So I think that, they worry, because the industry, industry is important to survive with us, okay?
Right.
So on the other hand, you understand, industry, to be successful, they look at the profit margin.
That's right. Not at the health of the patient.
A typical orthopedic company is 20 to 30% growth a year. Yeah. So how do they do that? They can grow by either have more market share, or they invent a new operation to try to promote.
That's right.
Okay?
Yeah.
Or maybe the new operation will get the market share too. And you see the company that are successful, they always have new things, put in, things, in my opinion, is not very good. For example, in the 80s, we have the LAD, and, it's like internal bracing today, and they say it's not the same thing, but it's the same idea. It doesn't work, artificial ligament. But now it's back to promoting with that, with the ACL, repair, things like that. So, like I say, the graph that we use will give you a 95% success rate if you do it for healing. So why don't you want to take a chance?
That's right. That's right.
There may be 5% of cases you need to do it. So if you look at my surgical, kind of indication, there are many different indications for different things. I don't do one operation, okay? I do multiple. Some single bundle, some double bundle for a big insertion size. I do augmentation sometimes, one bundle tear only. I sometimes do random preservation and repair maybe sometimes, and no surgery. In the rehab, also personalized. And also to tell people go back to like 4 months, I think a little bit too fast to me, okay? I don't think it's nonsense, but I think it's just marketing. And I'm going to tell you, I remember I have a female, 16 years old. A doctor say, you can go back in 4 months, and she went back the first time she kicked the ball, she returned the ACL. Yeah. So this is why I won't say it's nonsense, but it's just like, no good, okay?
No, right. Well, I have a final question for you, Dr. Fu. What should you give as a take-home message for patients?
Well, I think that, number one, I think if you turn the ACL, you understand it's not just the ACL.
That's right.
It's the ACL. You can disability. but you're gonna potentially get post-traumatic arthritic changes 5-10 years later. Okay, so it's a long-term thing. Okay, and so like I told you, the factors are trauma, biological, genetics, and poor kinematics.
Right.
Wrong surgery. So you must hopefully pick a surgeon to understand anatomy and hopefully individualize, and also value-based. Don't waste money. Okay, this is what I think.
Yes.
And also don't be in a hurry. Okay, don't be in a hurry. I mean, look, if you are going to Olympics in 4 months and you want to do it, I understand. So you can take a chance, but know that you need taught. Okay, and you will do that. But like you say, for regular people, hey,
take your time.
You're not Zlatan, okay? You're not like that, okay?
All
so
right.
just take your time and do it right. And also, you can always choose non-operative. I told you, I don't have a ACL for 20 years, and I live with it. I have a few buckling, but not horrible because I don't play competitive sports anymore, and I'm older. I'm 70 years old, so it's a big deal for me, okay? But for young people, maybe a big deal. So use your common sense, and don't go for new things, okay?
No, right.
Just not the greatest, okay? Don't believe this. Oh, I want a new thing. I want stem cells, okay? I have a patient coming to see me from New York, and he's giving stem cells and PRP for heal the ACL. Oh, it doesn't work, okay? So I mean, those are new things, and they cost thousands of dollars.
That's right.
It doesn't do anything, okay? So I just tell the patient that you should use those money to take your wife to a dinner or buy him a diamond ring because, those things, you have your own stem cells. Just like I told, the ACL already have stem cells between the bundle.
Yes.
It's right there. It's free. Okay?
Right.
Learning is forever, okay? I'm still learning about ACL.
Yes.
I still a lot of things I don't know. But I don't want to use gimmicky or silly things about ACL. I want ACL that really, like I showed you, the principles are what? It's dynamic, logical. There are bundles that work with the bone morphology. There's variation, and there's aging.
That's right.
So if you do 6 principles and think about it every time you approach a patient in surgery and do research, I think you're going to help the patients.
Cool. It's wonderful to see how much passion you have on your surgery and on your knowledge. It's incredible. Thank you very, very much.
Yeah, thank you. Bye-bye.
Bye-bye. Well, thank you very much for listening. And finally, I want to point to you that our next podcast drop in the series ACL Injury will be on Friday, the 30th of July, 1500 hours Central European Time. And it will be an interview with Professor Dr. Pier Paolo Mariani from Rome. Hope to see you then. Bye-bye.